Okay, so we're going to talk about BPD. So, in different parts of the world, depending on what system they use for diagnoses and whatnot, so they may or may not identify or understand or even be open to treat borderline personality disorder. So, we're going to talk about here, we're going to talk about, certainly what BPD entails. And then at the end, I'm going to talk about my approach in working with BPD and how to treat it. All right, or how I treat it. Now, one of the central concepts that we're going to talk about is a lot of individuals with BPD, they have a self-governing statement. So that this is what we say to ourselves, believe about ourselves, and what we operate from. And a lot of individuals with BPD, because there are three central concepts, which is fear of abandonment, rejection sensitivity, and emptiness. And a self-governing statement, a common one, and that doesn't mean everybody has the same self-governing statement, but something similar to it. So everybody kind of has their own nuance associated with it. And here we see it's to keep from being abandoned. Abandonment tends to be one of those core content areas, those central areas that when it gets activated, it activates all these maladaptive beliefs, behaviors, and patterns. Well, what makes them maladaptive? Well, the part of BPD is the D part, is the disorder part, is that individuals use maladaptive beliefs, behaviors, and patterns in order to regulate, manage, or control that activation of their core content. And in this context, we're talking about abandonment. But again, just as I mentioned, the three central core concept areas are fear of abandonment, rejection sensitivity, and emptiness. And these are pretty unique and specific to BPD as well. So this self-governing statement, we see that it drives a lot of individuals to engage in very destructive relationships, not only for themselves, the relationship they have with themselves, but also with others. Could be romantic partners, could be coworkers, could be other students, could be professors, could be with their students, could be with their supervisees, whomever it is that's in their interpersonal circle. So when we look at the prevalence, now this prevalence is for the United States. So we see that BPD prevalence here in the US is 3 to 5% in the general population. It's really not that high necessarily. But when we look at outpatient, we see that it goes up 10% in the outpatient population. So those are individuals that are in the general population, but that are receiving outpatient treatment. When we look at inpatient, these are individuals that are in hospitals, mental health centers that are getting treatment. And you see that it goes up to 20%. Well, why is this? Why do we see this increase in percentage based upon the particular environment that we're talking about? And a lot of times what we find is that when we go from general population, you're likely to have a higher preponderance or likelihood of individuals who can manage their mental health issues and concerns. Outpatient treatment is that it gets to a higher degree of individuals who need assistance in managing their mental health issues. And then for inpatient, you tend to skew higher as far as severity. So you find that individuals tend to, you find that individuals tend to have a less grasp or a weaker grasp or greater difficulty in managing their beliefs, behaviors, and patterns. So they require a higher intensity of treatment. Now, this preponderance or this change in percentage is also worldwide, not the specific percentages here, which are from the US, but we see that in different parts of the world, based upon individuals and their ability to manage their mental health, belief, behaviors, and patterns, we see that the greater the degree of intervention. Now, it's important to remember that that all BPD, like all disorders, is on the normal curve, right? We've all seen the normal curve, where it's that you get that meaty part kind of right in the middle, and that meaty part right in the middle, that is the majority of individuals that have the disorder, not just with BPD, but all disorders fall along that normal curve. The issue that is pretty specific and is related to the prevalence is that people forget that most disorders, BPD included, most individuals are going to fall within the moderate range, not the extreme range. Well, the issue with BPD is that a lot of mental health providers, researchers, and individuals in the general population who treat individuals in an outpatient population who also work in inpatient settings tend to have a stigma associated with BPD. So we see that these individuals tend to really misinterpret BPD, believing that it is only the upper 3%, meaning that they only recognize extreme cases of BPD. When we look at moderate, and we're going to talk about symptoms and issues in a moment, but when we talk about moderate symptoms, because people aren't looking for it, they miss it. So that's where the issue becomes in misdiagnosis, in it being poorly recognized, and most disorders, and this isn't just true for BPD, but all disorders, most are going to not fit into a nice, neat category of the disorder itself. We see that it's going to actually fall into an unspecified personality disorder with BPD traits, because we're talking about BPD, or it could be an other specified personality disorder with impulsivity, BPD traits, self-harm, whatever it may be. So those two components related to the Diagnostic Statistical Manual, and we're in the 5th edition, TR, right now as I'm talking about this. So we see that, again, you fall into more of those individuals that have traits or strong aspects of the disorder than will actually qualify for the full disorder. Okay. Now, BPD is the most commonly seen personality disorder in treatment, and that is not because these individuals are more severely mentally ill. It's because individuals with BPD are treatment seeking, as opposed to, let's say, narcissistic personality disorder. Those individuals are treatment rejecting. Antisocial personality disorder. Those individuals are treatment rejecting. Histrionic personality disorder. Those individuals are also treatment seeking. So we really, out of all the personality disorders in the DSM-5, and if we're talking about section 2, so that's 10 personality disorders, then we have only two out of 10, 20% that are treatment seeking, and that is BPD and HPD, histrionic personality disorder. So the overall presentation of an individual with BPD, this is a pervasive pattern of idealization and devaluation. It's a shifting in a sense of self, so you have that unstable self-image and fear of abandonment. This is part of that overall presentation. This is what you see when individuals initially present to treatment, or commonly see when these individuals present to treatment. And it is that they value others, they're wonderful superheroes, but then something happens and they devalue them, and they're the devil, the monster, the worst human being ever to exist. So we see that shift in idealization, devaluation, and then how they perceive themselves. And it's a difficulty understanding or committing to their own sense of belief and what they enjoy in life, because they tend to sacrifice themselves in order to get a sense of acceptance with others. And that goes to that unstable self-image and that fear of abandonment, which we discussed just a moment ago. Now, all of these traits, these central core components, which I mentioned, but just to reiterate, which is that these traits, they often lead to impulsive acting out, self-destructive behaviors, and it's really hard to maintain stability in relationships and how they see themselves because of these earlier factors, as well as rejection sensitivity and emptiness. So this factors into these individuals really having a lot of relationship impairment. And there's a lot of researchers, myself included, who look at BPD and say, well, is BPD a relationship disorder? And I'd love to hear from you what your thoughts are. When you think about BPD, do you conceptualize it within the context of relationships? Do you think, well, yeah, it's a relationship disorder. It's a relationship to self and a relationship to others, which are impaired. So is this a relationship disorder? It'll be interesting. You can You can put thumbs up, or you can put something in the chat if you want. That would be really great. If you want to throw something in there, kind of throw a thought in there, that would be cool. Okay. All right. And I know that, it can be hard to kind of conceptualize it, right? To think about these things. Well, I mean, is a relationship disorder? I mean, because of that instability in those relationships, right? So how does it manifest? How does it impact the individual and their relationships? So when we look at gender, if we break it down, now there tends to be a misconceptualization as far as the skew, which is its prevalence equality. So despite this common perceptions, actual prevalence of BPD is relatively equal between men and women. And this is in community-based studies, so in your general population. However, you tend to see that in females or women may be overrepresented in clinical settings due to gender biases and diagnosis. And this means, and this goes back to what I mentioned just a moment ago, which is that most individuals are going to look at BPD, they're going to use this confirmation bias lens, and they're going to say, well, BPD is female and it's females who act out and self-harm. So what happens is you get a preponderance of individuals being diagnosed, and in some cases misdiagnosed, because of that confirmation bias, and saying that, yeah, it's women who are acting out, who are perhaps aggressive, and who are harming themselves. The problem with that is that not only does it skew prevalence, but also you miss the majority of individuals with BPD because you're caught up in confirmation bias. So we always have to base our diagnoses and identifying these particular disorders based upon objective criteria. That's why assessment is so important in order to accurately define or identify BPD or any other disorder. Problem with the internet is so many people are self-diagnosing, and that's a huge problem, because the self-diagnosis aspect is that most people are only, again, they're looking for confirmation bias, so they're looking for BPD. They're not looking at the totality of the disorder. It tends to be skewed, which means in relation to gender that there's a higher preponderance of individuals that are going to look at females and say, yep, that's BPD. Also, females that may be going out and looking at the disorders and things like that are at a higher likelihood to self-attribute, which adds to the skew and misdiagnosis and prevalence of BPD. Now, presentation, men and women with BPD often show similar core symptoms. And this is why it's so important, because we got to look at oops, hold on, let me go back. We got to look at those core symptoms, that core content. Fear of abandonment, rejection sensitivity, right, and emptiness. Those are our core contents. For women, they tend to report some emotional instability, chronic feelings of emptiness, and mood reactivity, if we're going to break it down and specifically look at gender differences. For males, they often display more externalizing behaviors, aggressive behaviors, such as impulsivity and aggression. Now, here's where we see a huge skew in misdiagnoses, and that is that women who actually will qualify or are likely to present with antisocial personality disorder traits and the full disorder are more likely to be misdiagnosed with borderline personality disorder. Men with borderline personality disorder who actually have BPD, even though they're acting out impulsively and aggressively, they are more likely to be misdiagnosed with antisocial personality disorder. So this adds to a lot of that confusion as it relates to prevalence and accuracy in identification of these disorders, particularly BPD. Now, when we look at the diagnostic bias, and we're going to be tapping into some of the stuff that I just mentioned, but the higher rates of BPD diagnosis in women, this stems from a biases as to how the disorder is assessed and diagnosed rather than actual differences in prevalence. That goes to what I was just saying a moment ago. Also, when we look at clinical versus community findings, women are more frequently diagnosed in clinical settings, but broader non-clinical population studies show that BPD is not significantly more prevalent in females. This goes back to what I mentioned in the slide previously. These findings challenge the assumption, and this is why I love to do talks like this, particularly individuals at the university level or even at the high school level. This is really important because we have to push back on this stigma. We have to push back and add the reality to looking at BPD in different parts of the world because this is such a misunderstood disorder. Findings and challenging the assumption of BPD is much more common in females and highlight the need for careful diagnostic practice, meaning that we have to resist the urge to self-diagnose. I mean, you get online, you see the traits and stuff, you'd be like, man, do I have this? Hopefully, that will encourage people to then go to a qualified mental health provider who can then provide accurate, objective assessments and help that individual determine if the disorder is present or not. Instead, we get too many people that are self diagnosing, and then they may go for treatment. And a lot of times, we're talking about medication a little later, but they go to their medical provider, who medical providers work from the medical model, which is identify the disease and then treat it with medication. But the problem with that is that BPD can't be treated with medication. You can treat some of the overt or expressive symptoms, and that's what I call surface content, but it doesn't treat core content. There's no medication for abandonment, no medication for rejection sensitivity, and there's no medication for emptiness. And emptiness is not a criteria of major depressive disorder. So let's talk about the symptoms, right? And the criteria as they relate to BPD, specifically abandonment, which I mentioned, emptiness, which I mentioned, unstable self image, mentioned that as well. It's that difficulty in seeing yourself in a stable way, what you like, what you believe, and how you get a sense of satisfaction in your life. If you're not sure who you are, oh man, let me go back one more. If you're not sure who you are, it's hard to identify your interests and what you like and what gives you that sense of purpose. Purpose is so important to human beings because purpose is what drives us to achieve. It what drives us to get satisfaction out of our life. But if we can't understand ourselves, it's hard to identify that sense of purpose. Now, there's also a high reactivity, and this goes back to those maladaptive beliefs, behaviors, and patterns. Once that core content gets activated, then we act out in destructive, self-destructive, relationship destructive, interpersonal destructive patterns. And that adds that highly reactive. We don't stop and process and say, maybe I shouldn't punch my professor. Maybe I shouldn't, spit at that barista, right? I mean, those are extreme examples, but still, because what happens is you get so activated that it kicks off high reactivity, impulsivity, which you'll see there as well, intense anger. So we see that these facets are all this response to core content activation. That's why it is so, so important to understand our core content. Also, intense relationships. As you can imagine, if you're highly reactive, not sure who you are, afraid of emptiness, dealing with abandonment, it's really hard to be open and vulnerable in a relationship, whether it's with your parent, whether if you're a parent with a child, whether it's with your professor, whether it's with your employer, whether it's with your boyfriend, girlfriend, brother, sister, cousin, whoever it may be. And then self-mutilation. Now, self-mutilation, this is important to realize that not everyone with BPD self-harms. That is also part of the misunderstanding of BPD. People hold the idea that people with BPD, they harm. That's 100% conclusive statement, and it is wrong. Now, there is a high preponderance of individuals who do engage in self-harm behaviors who will qualify for BPD. But there are other disorders that have self-mutilation as well. That is PTSD, anxiety, psychosis, substance abuse, drugs and alcohol. So it's not just BPD, and this is with mental health providers as well. They misunderstand that. So what they do is they say, well, if you cut your BPD, I have worked with psychiatrists that have been in the field for a long time, and they would tell me that, well, if you cut your BPD, whoa. I usually actually say, whoa, depending on the type of relationship I have with that person. But I'll be, whoa. That is absolutely positively not true, and there isn't research to support that firm, definitive statement. Self-mutilation equals BPD. Absolutely positively not true. And we talked about impulsivity, intense anger. We also have to talk about dissociative, the dissociative experience. And dissociation is that you're separating from the experience of self. Presumably, all of us in this talk, we're all grounded. We're all aware of where we are. Maybe you're in a room, maybe you're in a classroom, maybe you're in your car, sitting there, hopefully you're not driving, right? And you're hanging out and you're aware of where you are and you have a sense of self in that environment. If you disassociate, it's almost like you're separating yourself from where you are. In some cases, people will report that they can almost look at themselves or they feel the experience of life as if it's just outside of arm's length. And typically, dissociation comes out of intensive stress response. Individuals with BPD are at a higher likelihood due to their poor management of stress to experience dissociative reactions as well as paranoia associated with poor management of stress. So, stress management techniques is really, really important for individuals with BPD. Now, associated features. Now, these are things that a lot of people don't even consider when they're going online, looking at stuff and things of that nature, because they only look at what's called criteria A. And this is the main 9 criteria, but there's more criteria than just criteria A. There's B, C, D. So we have to look at the other facets as well. Self-sabotage near goal completion. This could be dropping out of school. Relationships are going well. Maybe you feel like that person's going to propose or you feel like you might move in together. Then you blow up the relationship. Stress-induced psychotic-like symptoms. This is the experience hallucinations, as I mentioned, associated with dissociation. Body image distortions. You don't see yourself correctly, right? You may see yourself as overweight, underweight, gross, ugly, fat, distorted, whatever it is. So we see that it becomes out of stress-induced and it becomes more intensive. Reliance on objects over people for security. Now, this is that a lot of folks with BPD will often have like a pet or what's called a transitional object. A lot of my clients, the ones that I see in person as opposed to teletherapy, that they have transition objects. Sometimes it could be a business card of mine. Sometimes it could be like a little knickknack or something from my office. They're like, "Hey, can I have this?" Absolutely. If it gives them that sense of safety. I mean, it can't be anything, that like fancy. I mean, you can't have anything fancy, that's in my office. I don't really have anything fancy, but if I did, that'd be cool. But anyway, aside from that, I digress. But it's that reliance on objects, and pets are typical, is having this sense of security put into pets instead of people. I'm not saying one is right or one is wrong. I'm just saying this is a tendency that we see. There's an increased risk for premature death, especially from accidents or suicide. Accidents or suicide are often related to the component of high reactivity and impulsivity. So what happens is these people get under intense amounts of stress. Then they may cut themselves, hurt themselves, shoot themselves, hang themselves, whatever it may be. But a lot of times we see that it is driven out of that impulsivity. Typically, we see if they're not planned suicide attempts, they're more impulsive reactions to core content activation. Self-inflicted injuries can lead to physical impairments. I know it says handicaps, that's not an appropriate phrase, so I apologize for that. But that it can cause physical impairments. Sometimes people have cut some of their genitals. Sometimes they have cut their fingers off. Sometimes they have wounded their eyes, their ears, their hearing, their nose, things like that. So it creates these self-inflicted injuries that impair their ability to get through life and function to the best of their ability in life. Doesn't mean that you can't function well with physical impairments. Now, what I'm saying, we're talking about BPD and self-inflicted injuries. Common issues with job stability, education, and relationships. This goes all the way back to the first component on this page, self-sabotaging your goal completion. Is that you're about to have a real successful semester, so instead you blow it up. Maybe you stop doing your homework. Maybe you start arguing with professors. Maybe you stop turning in assignments, maybe whatever it may be. So you create all of this turmoil within those particular environments. And this is what we see, whether it's at work, could be in education, could be relationships, romantic relationships, familial relationships, friendships. History often includes, and this is also part of the confusion, often includes child abuse, neglect, or parental loss. So here, there's a big misconception that everybody with BPD has experienced childhood physical, sexual, and emotional abuse. That is absolutely not true. What the research shows, and this is research consistent for over the last 40 years, which shows that individuals that do develop BPD, the full disorder, they do have a higher preponderance or likelihood of childhood adverse events. And that can be childhood abuse, physical, sexual, or emotional. Could be neglect, could be parental loss. So we see there's a higher preponderance of that. But again, one does not equal the other. And that's super duper important. Super duper. Now, one of the big confusions is identifying and distinguishing borderline personality disorder from bipolar disorder. Now, the way that we would distinguish that, and again, this is best done by a qualified mental health provider, but let's just go over it so we have a conceptualization. For those with bipolar disorder, there's no discernible trigger to them acting out, whether it's impulsivity, whether it's gambling, promiscuity, whatever it may be. So we don't see that in bipolar disorder, but in individuals with BPD, we see typically probably exceptionally high preponderance of individuals that have that discernible trigger. Abandonment, right, episode, rejection sensitivity episode, emptiness experience, and that then causes them perhaps to act more manic-like, which is more hyper, impulsive, doing things, and being more aggressive, so on and so forth. Now, mood can last for days in bipolar disorder, not hours. And this means that most individuals with bipolar disorder, you're going to see those episodic highs and lows as they associate with the episodes of bipolar disorder. The high highs, hypomania or mania, and the lows, major depressive disorder. Those with BPD, they typically can have what are called florid BPD episodes. That means could be acting out impulsively, could be self-harm, could be aggression, could be high reactivity, whatever it may be. But typically it doesn't last for days. Typically it's hours. The longest florid BPD episode I have ever witnessed, regretfully, was 4 hours. This is an individual that was exceptionally elevated, really driven for self-harm, for self-destruction due to ending her life. And all of that came out of a experience where she was sexually attracted to someone, that person was not interested, and she internalized that, felt abandoned, rejected, and empty, which caused her to act out towards herself in a very violent and aggressive way. Depression is not predominantly associated with loss and abandonment in bipolar disorder, but you typically see that in those with BPD. Now, those with BPD, 85% of individuals with BPD are likely to qualify for major depressive disorder. But there's also an additional component with those with BPD, which is that they experience something that I call depressive spirals. Depressive spirals are experiences of depressive symptoms, but they are not so severe that you can't function. So they don't they aren't impaired to the level of what's called socioeconomic dysfunction, meaning that they can't operate in their world. They're not getting up for work. They're not getting up to take care of their kids. They're not getting up to shower. They're not getting up to go to the restroom. So they just go in their bed or something like that. In some cases, some individuals may wear a diaper, things like that, because they just don't have the energy to get and go to the bathroom. That's an extreme case of major depressive disorder. But for those with BPD, we see that they experience some of that hopelessness, helplessness, and worthlessness, but it is not to the same severity level and impacts their social right? And economic functioning, the same degree as major depressive disorder, okay? So, and tend not to self-harm. Bipolar disorder, individuals with bipolar disorder tend not to self-harm. There is a higher preponderance in those with BPD who do self-harm compared to bipolar disorder. So making that distinction is really important because we'll also see about 65% or so of individuals with BPD will also qualify for bipolar 2 disorder. That means they have a hypomanic episode as well as major depressive episodes. So we have to be able to see that, manage it, accurately identify it, because for bipolar disorder, there is medication to stabilize those episodes. If it is bipolar disorder and there's no medication to stabilize the episodes, treatment is just off the rails all the time. It's hard to get a sense of trajectory of going forward, of efficacy in the treatment and approach. So medication can be really important for bipolar disorder. Medication for BPD, again, treats a lot of those overt symptoms, that surface content, which I mentioned a moment ago, but it doesn't treat the core content areas. So BPD stays, but those other aspects of mania, hypomania, acting out, impulsivity, high reactivity, those can be attenuated with medication. So successful context for those with BPD: theater. You often see folks with BPD do really well in theater. Interior design, I'll tell you, I've been doing this for 20 plus years, and a lot of my clients have great taste and style. They really do. So interior design could be great, and they can be successful when they operate within a routine daily interactions. With all of my clients, I try to build around or with them a sense of routine, getting up at the same time, eating at the same time, engaging in work at the same time, or school at the same time. Human beings really prosper when we are operating within a routine. Human beings are just built that way. I don't know why. That's just how we work. Unsuccessful contexts, surgeons, be really hard for somebody with BPD because of the impulsivity, because of the emotional activations, to be a surgeon. To be in sales because you hear a lot of no's, that would be really hard. Daycare attendant can be really challenging because there's so much going on and it tends to be a very loud and intensive environment. Therapist. If individuals did not get their BPD under control, being a therapist can be really difficult because boundaries get blurred. So they start interacting with their clients in a much more interpersonal, overly connected manner, and you get lost in all of the pathology and all of the issues. And a lot of mental health providers, therapists, they experience what's called vicarious trauma because they hear so much about abuse or neglect or pain or difficulty in their clients that they can then internalize it and they get a sense of being traumatized. So it's this vicarious traumatization. Does not mean they can't be good therapists, does not mean they can't be good daycare attendants, does not mean they can't be good salespeople, does not mean they can't be good surgeons. What it means is you've got to get that BPD stuff under control in order to really succeed within these contexts if that's what the individual wants to do. Now, these 5 categories of approaches. So this is these 5 categories come from Laura Smith Benjamin, but these are the categories and approach that I use with probably 95% of all of my clients. The first we do is we collaborate against it. This is developing that mutual understanding that maladaptive behaviors are external, the external it, rather than the individual's true self. This is often manifested by individuals who say, well, I'm borderline. No, you're not. You have borderline personality disorder. We can pair this with cancer. Cancer, when individuals have cancer, they don't say, I am cancer. They say, I have cancer. BPD needs to be conceptualized in the same way, not as though it's cancerous, but that you aren't BPD. Your pathology, your issues aren't part of who you are. It is part of the disorder that you are experiencing and need to manage. Now, in working with my clients, we establish a sense of that we're in this together. We contract to promote an alliance even during really intense moments. It's you and me. We have to be aligned together. We have to work together against it. If we are not aligned, it's hard for me to help you manage your BPD beliefs, behaviors, and patterns. We have to work on empathy and balance it with boundaries and allowing for supportive but yet firm interventions. That means that we're going to have to put some boundaries in place as to how connected you feel with me, what's appropriate in session, what's not appropriate in session, and working through those things together. We then move to encouraging insight. And this is facilitating this pattern recognition. Like, you have to be able to see what's going on in order to manage it and deal with it. You have to encourage insight. And this is a step toward behavioral change. So you see patterns. This is essential, but only a starting point is recognizing. Insight is a part of therapy, not a goal. And that's really important because we want to help individuals trace how their past experiences and relationships shape their current behavior and emotional responses. We have to be able to make that connection because by seeing it, by having that insight, which you'll see in a further step, then we can deactivate it, and then you can learn new patterns of behavior and response. You're going to emphasize the goal of transforming these insights into healthier patterns and coping mechanisms. And we do that by managing certainly crises. Crises are going to come up. And this is, you have to prioritize life preserving actions. This can be extra appointments, doing crisis calls, over therapeutic insights during crises. Sometimes some of these recognitions can really activate a lot of core content issues. And that's where we have to build in, okay, when you get this activation, how are you going to manage it? How are we going to help you manage it? Once the individual gets stabilized during a crisis session, then you revisit the crisis triggers to prevent future episodes, not in the midst of it. In the midst of a crisis management session, you are trying to lessen the severity and the impact of the crisis only. You are not doing therapy. It is crisis attenuation only. And then after it's stabilized, you can revisit those crisis triggers, prevent future episodes, reinforcing that understanding takes place after immediate safety, building that understanding, that insight into that crisis activation. And you want to reinforce these crisis protocols like accessible emergency support. That could be me as their therapist, could be a crisis hotline, could be a healthy friend, could be a wide variety of different things that help the person function most efficiently. And we're going to gradually focus on the underlying patterns, but not within crisis management. Once the crisis is abated, then we'll go back and say, okay, remember when this happened? Let's build in some management strategies if that happens again. Once the crisis is abated, and then you're further along doing therapy and that person is stabilized. Now, underlying fears and wishes. And this is, we all have something inside of us that drives us to try to achieve something. What's interesting about individuals with BPD, they're driven towards blowing up their life, right? And that means that out of fear, of abandonment, rejection sensitivity, and emptiness, that they engage in these maladaptive beliefs, behaviors, and patterns to get their wishes or what they want out of life met, but it's driven by these underlying core content fears. So, to address this, we're going to explore those fears while also looking at what they desire, what they want out of their life experience. And we'll see that a lot of this is rooted in unmet emotional needs from past attachments. Could be caregivers, could be lovers, could be relationships that they had. And we support the individual. When I say we, it's me and my client working together to support them in recognizing destructive patterns that are driven by these attachments. We see that they internalize these patterns. Everybody on this talk today, you have internalized a pattern that you learned early in your life. hopefully they're adaptive, which is getting up on time, getting to school, doing your studies, right? Is it if you're in a romantic relationship about how do you treat that person? Those are usually early patterns that you learn from watching your parents or caregivers, and hopefully they're adaptive and healthy. So we have to allow for new and self-supportive goals. As you look at, contend with, and lessen the adverse impact of underlying fears, then you can learn new supportive ways to attain your wishes, what you want out of life. And throughout doing all this, we validate the individual's experience without reinforcing maladaptive patterns. I understand why you want to feel closer to people. However, and you don't necessarily say this because it's a very gentle process, but just to simplify, is that, I know you want to feel closer to people, but doing constant relationships tests, which is, well, I'm going to do this to see if he or she does that. And if they do that, then that means they don't really love me, or that means they do love me, or they means it's that, the other thing. So we have to do more adaptive strategies. You help them distinguish old influences from what they can do today in order to actively and healthily, right, adaptively achieve their goals. Also, blocking maladaptive patterns. Now, this is when we have all this insight, we have all this knowledge. That's where then we get to a behavioral level, and we're going to work together on techniques to resist or to stave off, delay self-harm urges or other destructive impulses. This can be that instead of arguing or testing your partner, what other ways can you get closer to them? So it's blocking those maladaptive patterns by doing tests. Maybe it's needling them, right? Getting them angry, seeing if they come back, right? Doing the breakup, makeup cycle, so on and so forth. Or encourage alternate activities. This is replacement treatment. Could be instead of acting out, calling a friend, going for a walk, doing a relaxation, doing some cryotherapy, doing a sauna, like a steam or something like that, to manage those immediate impulses. And you have to recognize and reinforce their need for consistent, underlying issue-focused sessions. Some sessions are going to be really focused on specific singular issues. And this helps to assure these strategies become part of that lasting change. So there's so much fluidity in working with individuals that have BPD that, as mental health providers, psychologists, myself, is that I always have a degree of fluidity. What works for this client, what doesn't? And sometimes it can be really, really challenging in identifying what works, because sometimes if they're not fully aligned with you, then they have a greater alliance to their BPD and maladaptive beliefs, behaviors, and patterns, and that decreases the efficacy and outcome of the treatment. But over time, hopefully, the individual becomes more aligned with me than they are with their BPD. And then finally, then we start facilitating new learning. And this is one of the problems, which is a lot of mental health providers start here, which is that they assume that the individuals that are coming for treatment already have these prior 4 aspects under control, which is they have good insight, they recognize their maladaptive patterns, they recognize and have the ability to block them, but they don't. A lot of times, facilitating new learning comes after having that insight, after that recognition, after challenging and seeing those patterns and doing things differently. So once we get to facilitating new learning, you got to practice and model new behaviors. This is your engage in role playing. If you're a big role player, I'm not with my clients, but a lot of mental health providers are. And you want to model adaptive responses to provide, concrete examples of healthier ways to handle challenging situations. You'll see a lot of self-help books, not mine. Mine actually goes through these 5 categories, but there's a lot of mental health workbooks, self-help books that start here. And I think that kind of misses the mark. We have to do these other 4 steps first. But introduce and reinforce coping skills. This teaches alternative coping strategies and provides real-time feedback to encourage consistent use of new tools. Also, encourage reflection and incremental change, meaning that it takes time. You have to have metrics. You have to have achievable goals. And you can use paradoxical interventions when they're beneficial, which is getting your needs met in a way that sometimes seems counterintuitive, which is you're driven to blow up your life, but instead using that energy in a more advantageous or positive way. It's paradoxical to amplify the individual's energy, but you're going to refocus it on something that is more beneficial or helpful to them. And always psychoeducation about themselves, the world, building that sense of stable self-image so they can gradually adopt and understand healthier behaviors and thought patterns. So that is my presentation. We got a few minutes for questions. If anybody has them, please let me know. I appreciate your attention. That was really great. Thank you. Okay, Gabriella, let's see. Okay, how to help and support a loved one with this disorder. Okay, so I think first and foremost, if it is maybe a partner or a friend or a family member, I think that what you have to do is it's a really gentle approach. First, recognize that the individual isn't acting this way because they want to. And that's where I think the greatest degree of stress is with a lot of family members, is that they get annoyed because they're like, well, he or she's choosing to do this. He or she is doing and I'm not saying that they shouldn't be held accountable for their behavior. What I'm saying is you have to understand that this individual doesn't know a better way of functioning. Also, with a loved one, don't try to intervene when everything is on fire. Strike when the iron's cold. That means that when everything's calm, pull that person aside, take them out for a coffee, take them out, not alcohol, bad. Don't take them out for a drink. That's usually not good. But take them out, for something where you can have an open and clear conversation about what can I do that when you start to get activated or you're afraid or you feel like everybody's going to leave you or whatever it may be, how can I help you best? And that opens the door. Using a lot of open-ended questions is really helpful, but that can open the door to problem solving, identifying those issues, building that sense of insight. And if the person says, I don't know, say, well, what do you think about maybe we can learn some strategies together that could be helpful? Now you're working with the person, not forcing them or against them to engage in more adaptive patterns. So, Gabriella, great question. Great question. Hey, Gosia, I hope I'm saying it correctly. Good evening. What was your most difficult case of a patient with BPD? Is working with such a patient during therapy difficult? Thank you very much. Oh, you're very welcome. My most difficult case, that's really tough. I think a challenging, probably one of the most challenging case. I don't know if it's the most difficult, but the individual that I mentioned with her 4-hour florid BPD response, and part of that was that in working with her, she she even though I think she believed that I was a helpful individual, like I was really there genuinely to try to help her, but her BPD and what's called family in the head, and we didn't get into it today because we didn't have time, but it's this chorus in our brain that tells us, it's like self-talk, but it's really amplified. And it's there's good and bad family in the head. And individuals with BPD tend to have a very loud, negative, maladaptive family in the head. So I think with her, what made it so difficult was she kept on not only listening to, but saying, well, these negative beliefs, I mean, they fit with my old patterns, so it must be right. So what you're telling me sounds good and makes sense, but I'm not going to engage in that. So I'm still going to engage in these maladaptive, destructive behaviors, even though it got me in prison. My family has disowned me, even though it got me addicted to heroin, even though, I engaged in prostitution in order to manage my physical, emotional, monetary needs and all of these things. So I think that was part of the difficulty in working with her for 2.5 years. I can say that a lot of that did attenuate, meaning that her self-destructive behaviors, they got less so. But I think that was always an issue we had, is that she was always reluctant and seemed to have a barrier between us. As much as I tried to align with her, it was really hard to have full alignment with her and for her to really embrace trusting me. And that doesn't mean that it's her fault. I understand where it came from. She's Her history is exceptionally horrific. There's no other descriptor that I think can qualify. So I understand. I think if I had more time with her, so I worked in the prison system here for the federal government for 21 years, and that's where I saw her for 2.5 years. She was eventually released from prison, so that's why we no longer work together. But I think if I had her for maybe another year and a half, 2.5, maybe 3 years, I really think we could have worn down a lot of that family in the head, BPD tendencies. Great question. Great question. We got another one by JM. Is it possible to get this presentation? I can make handouts and I can send them to Gabriella, who can then send it out. Yep, I'll write myself a note. So I will send a handout. Sure. Absolutely. Absolutely. As a PDF. I'll send a PDF handout. Yep. All right. Can you say something about age regression in BPD? How and why this happens? So I think when you say age regression, I think what you're saying is the utilization of what are called immature, and that isn't derision, but that they tend to be immature traits in order to manage issues, which could be tantrums, could be really volatile, aggressive responses. That's often what people mean when they say like age regressions in BPD. So I think that that's because individuals with BPD, but also other personality disorders, is that they tend to overly rely on maladaptive strategies. That as adults they're maladaptive. Just like in the client I was talking about a moment ago, a lot of her strategies were adaptive when she was a child in very abusive, self-destructive environments, that she used her violence, she used her aggression, she used her self-attack in order to manage the environments. But as she got more efficacious, she didn't see that as an adult, she had greater control over her world, over her response, but she couldn't see that because her family in the head and her patterns became so internalized. So I hope that that answers your question. Great question. Uh, Banui, I hope I'm saying it right. I always try to pronounce everybody's name correctly, and I just have a few more minutes, so I'll try to get to as many questions as I can. Could you say something more about differential diagnosis? Sure. So for differential diagnosis with BPD, what we're looking for are those four core content areas. That's a real big distinguisher from other disorders, which is, as I mentioned, fear of abandonment, rejection sensitivity, and emptiness. We don't see those in other disorders. So that can help us differentiate BPD traits or the full disorder from other disorders, even though they may look on the surface to be all the same, right? Acting out behavior, aggression, self-destructive behavior, substance abuse, all that other stuff. So there's so many disorders. There's PTSD, there's anxiety disorders, depressive disorders, bipolar disorders that also have acting out, aggression, substance abuse, all that. But they don't have abandonment, rejection sensitivity, and emptiness. So going to that core content, that's why it's so critical. And I think, that so in my workbook, even in the Polish one, I'm glad to hear that it's translated well, but even in the Polish one, that it talks about identifying your core content and helps individuals do that. Which psychotherapy trend is best? So really, I think it depends upon the individual, what works best for that individual. For me, I use a combination of what's called object relations and interpersonal. I use some cognitive behavioral techniques, but typically I use that once we're much further along and we've established alignment, we've established a good degree of insight into self, patterns, fears, and wishes. So really, there isn't one therapeutic approach. Now, DBT, even though it is housed in cognitive behavioral therapy and is great, it is absolutely great in treating BPD. And even DBT takes from interpersonal because it talks about interpersonal relations, interpersonal therapy, talks about, it doesn't necessarily get too much into object relations, but it taps into the outside of it. So it touches a little bit on it. but definitely a lot of interpersonal aspects in DBT as well. So I hope that answered your question. And Gabrielle, as I see, I got another couple minutes and I got to run. But Gabrielle, how to work with a patient on introducing tendencies such as the inclination to blow their life out or up into dreams or imagination. So again, I think that you have to address these things. You're going to be doing it successively, meaning that as you're building insight, you start to talk about like how do you see yourself unfolding? How do you see your life unfolding? Because I think that we are, meaning human beings, we are really almost like image driven people or species because we see a particular aspect, like how we want to live our life. And interestingly, we engage in behaviors that increase the probability of attaining that. If it's self harm, if it's self destruction, you see that these individuals do just that. So a lot of times we're contending with how you're seeing yourself, the image that the person has in their head. That's why it's so important to talk about not only thoughts and feelings, but also the images that are in their head. And can we reframe those to be more adapted to help you move forward in a positive way? Hope that answered your question. So I see we have 4 more questions. I don't think I'm gonna be able to answer all those. So I'm gonna do 2 more, and I apologize that I wasn't able to get to all of them. How to prevent BPD person from anger towards psychologists and from ending therapy and trying to find another therapist, and why do they do this? So a lot of times what you get is that you get a sense of like attachment reactivity, which is in therapy, there's always an attachment pattern or sequence that gets played out. So when I first start working with someone and we start to get intimate, and by intimate, I mean close, emotionally close, right? Obviously, I don't mean sexual, but there's a lot of different levels of intimacy, right? So just to clarify. So once we start to get a sense of closeness, I see individuals start to maybe miss sessions, push back, like, how is he going to respond? They go into those testing behaviors. They give you a good example. It's a lot like a 2-year-old being on the playground. And when you bring a 2-year-old to a playground, right? They hang out with you at first, they survey the playground. Is everything cool? Is everybody okay? Then they go off in the playground. Then maybe they make new friends. They're playing in a sandbox. They're doing this, they're doing that. And they come back to you to check in with you. Therapy plays out the same way. I think that a lot of psychologists and mental health providers get frustrated because they're like, well, if they're not showing up, then da, da, da. For me, I counter that by identifying what they're intrinsically motivated to achieve in therapy. And then I'll talk about if I see that that attachment is getting a little overwhelming for them, then we'll talk about it. And I'll say, sometimes when we start to get close to people, we start to test them. Do you feel that way? Like, do you feel that as we get closer and as we're working on more stuff, do you feel more fear coming up? What's that like for you? And we open it and process it. Because remember, we're about alignment and working together against it. If your client sees that you are safe, that they can align with you against their maladaptive beliefs, behaviors, and patterns and achieve what they want out of life, they will often stay in treatment. Sometimes anger is their go-to response. And I think when I have clients that do get angry, I'll say, I understand where you're coming from. Or I'll say, I don't understand the anger. Help me understand it. Give me some insight so you and I can work on this anger that you have towards me. I don't mind anger and anger expression. Sometimes it's a good thing. And Paulina, you'll have to be our last question for today, but I appreciate everybody and their questions. What was your beginning in working with patients with BPD like? What were your experiences, impressions, and thoughts? Wow, Paulina, that is a great question. Um, so initially, where I was trained in my doctoral program, many of the professors were in the field 40, 50 years and things like that. So we had a conceptualization of personality development, maladaptive belief behaviors and patterns, and as they relate to conception of self as well as working with others, meaning that how you see yourself and how you operate with friends and with lovers and with coworkers and parents and all that. So they prepared me really well. The part that I think I got overwhelmed with and a little scary in the beginning is because, and I see this even in my students, in my doctoral students that I work with, as well as supervising psychologists for licensure, they want they want to be pleasers in some ways. Like, you see somebody in distress and you want to help them. The best way to help them is to align with them and help them work their way through it. I think earlier on, I became so solution focused, but there's no solution or easy solution, better way to frame it, to fear of abandonment, rejection sensitivity, or emptiness. It is a process. It is about building insight. It's about those 5 categories that I mentioned, and it takes time. And as much as it's so hard to see someone in distress and struggling, that being open and wanting to connect with them and really always being transparent, like I'm always transparent with my clients. That doesn't mean it's always a good thing, but in a way it is always a good thing, because what you see is what you get. And a lot of folks with BPD have experienced so many disingenuous, inauthentic people in their lives that had ulterior motivations, that when you start working with someone who is transparent, they start to get a sense of safety and they're able to connect in a much more healthier way. And that's really my goal. Great question, Paulina. I gotta tell you, that's a great question. Okay, well, and I know there were other great questions, and I apologize. I do have to run, but I do want to say thank you all very much for your time and your attention. And I do respect everybody's attention and their time. And you're very, very welcome. I see there's some thank yous up there. That's really awesome, and I appreciate it. And if there is more that I can do, please reach out through email. And Gabriella, I believe, has my contact information. And thank you all very much. Thanks.
Great. I'm Kosha. I'm with Gabrielle, and we really thank you, Professor, for such an engaging and inspiring lecture. Your knowledge is experienced and truly invaluable, and it has been an honor to listen to you today. We sincerely hope to have the opportunity to repeat this experience in the future, and would be a delight to host you here in Poland, should you ever have the chance to visit.
Well, thank you very much. I would love to go there sometime. So that would be great. And I enjoyed this as well. So everybody have a good day, and please be safe and take care.